Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to the deep dive. Today we're really getting into a topic that's incredibly important, but honestly still too often in the shadows. Men's mental health. It's this strange paradox, isn't it? A kind of silent epidemic. You might hear that and think, oh, it's just that men don't ask for help.
Right, the simple answer.
But the sources we've looked at, well, they show it's much, much more complex. It points to systemic problems.
That's exactly right.
Yeah.
Our mission today is to dig into why this disparity exists, why these tragic outcomes.
And what can be done.
And what can be done.
Yeah.
We're looking at a two-pronged solution that our sources propose. It's not just about individuals.
Yeah.
You know, it's about fundamentally reevaluating the mental health care system itself.
Training, practices, the whole thing.
Yeah. How do we make it work better for everyone? Especially for the men it's currently failing.
Okay, so let's start with the hard numbers.
Yeah.
Because they really paint this picture, you know, this invisible crisis.
The lethal paradox, really.
Yeah. Did you know in the U.S., men die by suicide? It's something like 4 times higher than women.
4 times. It's a shocking statistic when you hear it laid out like that.
And this detail is just heartbreaking. Older white men, aged 85 plus.
Yeah, their rate is the highest.
Yeah.
Of any group.
Significantly higher.
4 times the general population
Yeah.
rate. These aren't just numbers, right?
No, definitely not. They're stark indicators of this deep, deep pain that's just not being addressed effectively.
And it's not only suicide.
No, substance abuse, too. The sources highlight that 68,000 men in the U.S. die every year from alcohol-related causes.
Compared to 27,000 women, that's more than double.
It is. And again, these numbers, they just scream about the fatal consequences when psychological suffering goes unseen, untreated. Preventable deaths, often.
Which leads right into what the sources call this critical help-seeking gap. There was a big survey, the National Health Interview Survey. It found that among men who said they felt depressed or anxious daily,
yeah.
only 1 in 4 had actually talked to a mental health professional. 1 in 4. It's such a low number. And it's tempting to just say, see, men are unwilling.
Okay, case closed.
But our sources really push back against that simplification. They argue it's not just an individual failing, it's a systemic inadequacy. The system isn't providing care that resonates.
Care that understands maybe how men are socialized, how they show distress.
Exactly. So why is this gap so pervasive? We need to unpack the reasons. It's multifaceted.
Okay.
A major piece is, well, the socialization of masculinity, how boys are raised.
The traditional norms.
Yes.
Yeah.
Those restrictive gender norms, emphasizing stoicism, independence, always being strong, in control.
Don't show weakness.
Precisely. So seeking help, showing vulnerability, that gets framed as weakness. Failure, you hear things like man up.
Yeah. We've all heard that.
And it leads to what psychologists call emotional restriction. It makes it genuinely hard for men to even recognize or name what they're feeling.
Let alone talk about it.
Right, they bottle it up, as the saying goes.
Yeah.
Which we know actively harms well-being. It doesn't just stay bottled.
No, it comes out somehow. Which, you know, that makes me think about how we even define depression. Is it possible we're missing something?
That's a fantastic question. And our sources introduce this really interesting concept, the male depressive syndrome.
Okay, tell me about that.
It suggests that instead of the classic internalizing symptoms we often associate with depression, like persistent sadness, crying, withdrawal.
The things diagnostic checklists often focus on?
Exactly. Men's psychological pain frequently manifests differently, more externally.
Like how?
Think increased anger, irritability, maybe aggression, or controlling behavior. Sometimes escapism, like throwing themselves into work or sports. Excessively.
Risk-taking, like reckless driving, substance misuse.
Yes, exactly. Significant risk-taking. It's like they're acting out the pain because the norms forbid just saying, I'm hurting.
Wow. That makes so much sense, but it also means...
It creates a huge diagnostic challenge because the standard tools, the questionnaires, the criteria...
They weren't designed to pick up on those behaviors as depression.
Largely, no. They were often developed based on symptom clusters more common in women. So they just miss these male expressions of distress.
So men might not get diagnosed not because they aren't depressed, but because their depression looks different.
Precisely. And there's this really eye-opening study the sources cite. Researchers used a gender-inclusive depression scale.
What did that include?
It included things like rage, risk-taking, substance use, those externalizing symptoms we just talked about.
Okay. And what happened?
When they used that scale, the lifetime rate of depression found in men was 30.6%.
And how does that compare to women?
No significant difference.
Wow.
Yeah. So what that study really tells us is that maybe this perceived gender gap in depression rates, it might just be a measurement artifact.
We were using the wrong ruler.
Kind of, yeah. We were asking the wrong questions, or maybe not enough of the right questions. It's not that men aren't suffering as much, it's that their suffering often looks different, and our tools weren't built to see it.
That's huge. It totally reframes the conversation, doesn't it?
It really does.
And, okay, another crucial point our sources stress is the need for an intersectional lens. Because men isn't one single group, right?
Absolutely not.
Right.
It's so important. Men's experiences are shaped by race, ethnicity, sexuality, class, all these intersecting identities.
So, like, talk about Black men.
Okay, so Black men navigate those traditional masculine pressures we talked about,
Right.
but also face the constant stress of systemic racism, and often a very justified mistrust of institutions, including healthcare.
Right. So a therapist needs to get that.
A competent therapist needs to acknowledge the reality of racism, validate that experience, while also maybe exploring their relationship to male privilege in other contexts. It's complex.
Definitely. Or LGBTQIA plus men.
Exactly. They face unique stressors, societal prejudice, discrimination, maybe internalized homophobia or transphobia. These intersect with masculine expectations in really intense ways, creating internal conflicts.
And things like unemployment, losing a job, relationship breakdown.
Huge risk factors.
Yeah.
Socioeconomic status plays a massive role. So effective therapy needs what the sources call strong intersectionality.
Strong intersectionality. What does that mean in practice?
It means looking beyond just the individual identities like man and black and analyzing the intersecting systems of power, privilege, and oppression that shape that person's whole life.
So understanding how racism, economic pressure, and gender norms all interact for that specific person.
Precisely. Seeing the whole context, not just the presenting problem.
So given all these barriers, the socialization, the diagnostic issues, the intersectional complexities, the proposal our sources make seems pretty clear.
It is a new standard of care.
Through mandatory intersectional gender competence training for all mental health professionals.
Yes.
Mandatory.
So let's unpack that term, gender competence. What does it really mean? Is it just being aware?
It's much more than just basic awareness. It's defined by a therapist's actual demonstrated ability to get positive results with clients of any gender.
Any gender, which requires understanding gender not as a simple binary, but as this complex, fluid thing shaped by culture, psychology, social factors.
And how does that translate into practice?
It's operationalized through something called the gender-affirming model. Key principles are unconditional validation, respecting the client's identity and autonomy, informed consent, non-discrimination.
So basically creating a genuinely safe, non-judgmental space.
Exactly. For all clients, including cisgender men, allowing them to explore the pressures and contradictions of their own gendered experiences without feeling judged or pathologized.
That feels like it should just be standard practice, ethically.
You'd think so. And the big professional bodies, like the American Counseling Association, they do require cultural sensitivity, including gender.
Oh.
But the body that accredits most counseling grad programs, KCREP, our sources criticize it for a notable lack of direct mention of gender identity and its standards.
Wait, really? The accrediting body?
Yeah. And if they set the curriculum and they're not explicitly requiring this,
Then new therapists are graduating without this crucial training.
which leads directly to the harm we talked about, misgendering, invalidation.
Clients having to educate their therapists, which is not their job.
Absolutely not. It's an ethical failure, really, and a huge barrier to care.
So what would effective training actually involve? What are the components?
The sources outline 4 core areas based on solid frameworks. First, counselor self-awareness, really examining your own biases about gender, masculinity, everything.
Okay, looking inward first.
Critical. Second, client worldview, gaining deep knowledge about diverse gender identities, about masculine socialization, intersectionality.
Understanding the client's context.
Third, building an affirming counseling relationship. This is about practical skills using respectful language, building trust, demonstrating that validation we mentioned.
Making the therapy room feel safe.
And fourth, counseling and advocacy interventions. Learning how to integrate the understanding of systemic oppression into the actual therapy work, and maybe even advocating for clients systemically.
So it's about putting that strong intersectionality into practice.
Exactly, making it real.
And do we know if this kind of training actually works? Is there evidence?
Yes. Pilot studies looking at LGBTQ plus cultural competence training, which is a pretty good proxy here, show real, measurable, positive effects.
Like what?
Tangible changes in the clinic's climate, improvements in therapists' own attitudes, their confidence, their self-efficacy, and importantly, their actual use of affirming practices with clients.
So it builds the trust needed for therapy to even start effectively.
That's the key. It builds that foundation of trust and safety.
Okay, so training is the foundation. Absolutely crucial. But therapists also need the right tools, right? Specific approaches.
Definitely. The training has to be paired with effective therapeutic models.
And the sources suggest promoting male-tailored approaches, which I want to be clear, doesn't mean like a therapy light or something.
Not at all.
Okay.
It means approaches that strategically align with common masculine communication styles. Maybe more practical, action-oriented, solution-focused.
Makes sense. So what models are we talking about?
Our sources highlight 3 really powerful ones. First up, action-oriented cognitive behavioral therapy, or CBT.
CBT. Many people have heard of that.
Right. But maybe focusing on its action-oriented aspects. It's structured, it's goal-oriented, focuses on practical skills.
Things you can do.
Exactly. Things you can do. Measurable progress. Homework assignments. This often aligns well with a preference for action and problem solving.
What are some key techniques within that?
A big one is behavioral activation. It's kind of an outside-in approach for depression. You work with the client to schedule activities, things aligned with their values, even small things, just to build momentum and break that cycle of withdrawal.
Get them moving again, basically.
Yeah. And then there's cognitive restructuring, helping men identify and challenge those negative thought patterns, which are often tied to rigid masculine ideas like, I have to be in control all the time, or showing sadness means I'm weak.
Okay, so CBT is one tool. What's next?
Next, we have strength-based framing and something called the positive masculinity model, or PPPM.
Positive masculinity. Interesting.
Yeah, this represents a really crucial shift. Instead of only focusing on problems or deficits.
What's wrong with you?
Right. It actively looks for and leverages the client's inherent strengths, their virtues, their resilience, reframing their story from victim to survivor or even thriver.
I like that. And the PPPM?
The PPPM specifically identifies 10 characteristics often associated with masculinity, things like generative fatherhood, male ways of caring, the worker-provider tradition.
Things that can be really positive.
Exactly. When they're enacted flexibly, they can be profound strengths, sources of identity and meaning.
So the therapist helps the client see those strengths in themselves.
Yes, by identifying and affirming these strengths first. You build that alliance, you reduce defensiveness. It's like saying, look at what you do well. Look at these positive aspects of your identity.
Which probably makes it easier to then talk about the harder stuff.
Precisely. It creates a secure foundation. From there, you can gently explore how maybe a rigid or inflexible attachment to those same roles might actually be causing strain or conflict.
Okay, that makes a lot of sense. Build on the strengths before tackling the challenges.
Right. Which leads to the question, how do we address those deeper internal conflicts compassionately?
And that brings us to the third model.
Yes. Internal family systems, or IFS.
IFS. I've heard more about this lately. It's quite different, isn't it?
It is. It's a really powerful, non-pathologizing model. It sees the mind as naturally multiple, made up of different parts.
Parts, like personalities.
Not quite like multiple personalities, more like sub-personalities or aspects of ourselves. IFS categorizes them broadly.
Yeah.
There are exiles, which are the young, vulnerable parts holding pain, fear, shame from past experiences.
The wounded parts.
Yes. Then there are managers, who are like proactive protectors. They try to control things, keep us safe, prevent the exiles from getting hurt again. Think perfectionism, controlling tendencies, hyper-rationality.
Okay, internal strategists.
Good way to put it. And then there are firefighters. These are also protectors, but they're reactive. They jump in after an exile has been triggered, trying to douse the emotional fire, often with impulsive or extreme behaviors.
Like what?
Like substance use, rage outbursts, binge eating, excessive gaming, things that numb or distract from the exile's pain, but often have negative consequences.
Right. The stuff that often gets labeled as the problem.
Exactly. And crucially, IFS says that beneath all these parts, there's the self, with a capital S.
The self.
Yeah, the core of who we are. It's characterized by qualities like calm, compassion, curiosity, confidence, connection, creativity. The goal of IFS isn't to get rid of parts.
You can't. Right. They're parts of you.
Right. The goal is to heal the wounded exiles and to help the managers and firefighters unburden from their extreme roles so they can function in healthier ways, allowing the self to lead.
How does this apply specifically to men then?
Well, it provides an incredibly useful map. Many of those extreme protective parts align directly with traditional masculine scripts.
Ah, like the stoic manager, the angry firefighter.
Precisely. The stoic, hyper-rational, workaholic manager part is very common. And the angry, aggressive, or substance-using firefighter part, that often is the externalizing male depressive syndrome we talked about earlier.
So IFS gives you a way to understand those behaviors without just judging them.
Exactly. Instead of labeling a man's anger as toxic, an IFS therapist approaches it with curiosity. What is this angry part trying to protect you from? What younger, more vulnerable part is it stepping in for?
Helping the man understand his own anger rather than just condemn it.
Yes, seeing it as a firefighter desperately trying to protect an exile, holding feelings of, say, inadequacy or deep hurt. This reframing is profoundly destigmatizing. It allows men to access and heal the underlying wounds and helps those protective parts relax their extreme roles.
That sounds incredibly powerful, and I can see how these three models could work together.
There's a real synergy. A man might come in, maybe resistant, but open to the practical, skill-building nature of CBT.
Get some immediate tools.
Right. Then, as trust builds, the therapist can use strength-based framing to build his confidence, counter shame. You have these resources within you.
Creating a stronger foundation.
And that foundation of skills and self-efficacy creates the safety needed to then do the deeper, sometimes more challenging work of IFS healing those core wounds held by the exiles.
It feels like a really logical progression, tailored but deep.
Exactly. A potentially male-sensitive and transformative therapeutic journey.
Okay, this all sounds fantastic. The training, the models. It feels like a really solid plan. But, there's often this gap, isn't there, between the research, the great ideas, and what actually happens in clinics day to day.
Yes, the infamous research-to-practice gap. It's a huge challenge in healthcare generally, and mental health is no exception.
So how do we make sure these evidence-based solutions, the training, the models, actually reach the men who need them? How do we bridge that gap?
This requires a really deliberate, systematic approach. There's a whole field dedicated to this, actually, called dissemination and implementation science, or D&I science.
D&I science. Okay.
Dissemination is basically about actively spreading the information, getting the training curricula, the therapy manuals, the research findings out to the right audiences.
Making people aware.
Right. But awareness isn't enough. Implementation is the next step. It involves using specific, planned strategies to help clinics, organizations, individual therapists actually adopt, integrate, and sustain these new practices.
So not just telling them about it, but helping them actually do it.
Exactly. It's all part of what's called knowledge translation, or KT, moving knowledge into action. And it usually requires attacking the problem from multiple levels.
Like top down and bottom up.
Precisely. Top-down strategies are crucial. Think about the accrediting bodies like KC-REP for counselors, APA for psychologists.
You mentioned them earlier?
They need to revise their standards to explicitly mandate this kind of intersectional gender competence training in all graduate programs. Make it non-negotiable.
So future therapists get it from the start.
Yes. And licensing boards in each state. They should require specific continuing education units, CEUs, focused on male-sensitive or gender-competent modalities for getting licensed and renewing that license.
Keeping current clinicians up to date.
Exactly. Then you have bottom-up and sort of horizontal strategies. Professional organizations, the APA, ACA, social work associations, they can develop best practice guidelines, host workshops, conferences.
Spreading the word among peers.
Yes, and fostering things like practice research partnerships or learning communities, where researchers and clinicians work together to figure out how to adapt and implement these practices in real-world clinics with real-world challenges.
That sounds sensible, but change is hard, right? Especially in big systems like healthcare. What are the roadblocks, the barriers to actually making this happen on the ground?
Oh, there are many. And we have to be realistic. You've got systemic barriers, things like lack of funding for these training initiatives, or insurance policies. Will they actually reimburse adequately for these specific therapies.
Good question. If it's not billable,
It makes it very difficult. There can even be political hostility towards gender-affirming care in some places, which could unfortunately impact these broader gender competence efforts. Overcoming these requires real advocacy work at policy levels.
okay, what else?
Then there are organizational barriers. Within a specific clinic or hospital system, you might face institutional inertia, just this is how we've always done it, or maybe a lack of buy-in from leadership. The culture might not prioritize this kind of training.
So how do you tackle that?
Strategies could include training the clinical directors, making them advocates, or identifying and empowering internal champions therapists within the organization who are passionate about this and can help drive the change from within.
Makes sense. And
Finally, you have individual barriers for the clinicians themselves. Resistance to change, maybe they feel comfortable with how they practice now. Lack of time is a huge one. Clinicians are often overworked already, or just feeling overwhelmed by learning something new.
So mandates alone aren't enough.
Definitely not. You need high-quality, engaging training that doesn't feel like just another burden. And critically, ongoing support, like consultation groups, supervision to help clinicians build confidence and problem solve as they actually start using these new skills. Implementation needs ongoing support to stick.
Wow. Okay, so pulling this all together, what's the big picture here? Our deep dive, it really shows this silent epidemic in men's mental health is, well, it's profound. The current system is often failing.
At a tragic cost, yes.
But it's not hopeless. This dual strategy we've discussed, mandating the intersectional gender competence training and actively disseminating these tailored therapeutic models.
It offers a really comprehensive, evidence-based path forward. It addresses both the foundational understanding and the practical tools needed.
And just to reiterate, this isn't about creating some separate men's therapy silo, is it?
No, not at all. That's a common misconception or fear. It's about making the entire mental health care system more flexible, more culturally aware, more sophisticated, fundamentally more effective for a huge part of the population that's currently struggling to reach.
So every clinician has the knowledge and the tools.
Exactly. The foundational understanding of gender, intersectionality, masculine socialization, and the practical skills from models like CBT, strength-based approaches, IFS, turning understanding into actual healing.
You know, when you think about the potential impact, it goes way beyond just the individual men being helped, doesn't it?
Oh, absolutely. Imagine the ripple effects.
Yeah.
Healthier individuals mean healthier families, more equitable relationships, potentially safer communities. The positive impact could be immense.
It really could be transformative. Which leaves us, and you, with a final thought to consider. If we truly start recognizing and addressing these systemic issues in men's mental health, how might that reshape our whole understanding of societal well-being? Not just for men, but for everyone.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.